The founding dean of the National School of Tropical Medicine, Dr. Peter Hotez, wrote a couple of interesting articles recently, and I wanted to talk to him about them. One is about the parasite that most people who are not in our profession or in the military probably never heard of, leishmaniasis. And the other is about a mystery disease that's killing young Central American men. Joining me on the phone now is Dr. Peter Hotez. He's the president of the Sabin Vaccine Institute and the founding dean of the National School of Tropical Medicine at the Baylor College of Medicine. Good afternoon, sir, and thanks for coming on today.
Hi, thanks for having me.
Thanks for coming on again, as a matter of fact. Let me steal the first line of your article published in the Huffington Post late February. And it says, one of the least known consequences of modern conflict in the Middle East and East Africa has been the widespread devastation that results from the tropical infection known as leishmaniasis. As most people who watch the news, we see the carnage of war and other conflicts in the Middle East. However, this is an unseen threat, and it's ignored by most media. So, in the simplest possible terms, Dr. Hotez, what is leishmaniasis, and what's going on in Syria and those other countries of conflict concerning leishmaniasis?
Well, thanks for asking. So I like to sometimes call leishmaniasis, as I do several of these neglected tropical diseases, the most important disease you've never heard of. This is, when you think of the consequences of war and conflict, not many people give adequate thought to some of the outbreak of diseases that can happen, but people are aware of the problem of cholera, for instance, which will often happen after calamities such as the earthquake in Haiti. But almost no one has really heard of leishmaniasis, but yet it now ranks as one of the most important, if not the most important, diseases arising in the setting of war and conflict in all modern wars. And I'll give you two examples. One of them is what happened during the war between North and South Sudan, the Civil War, where you had, during the 1980s, where you had people fleeing the conflict and heading towards refugee camps along the border with Ethiopia. During this period, there was malnutrition and a lot of exposure to the bites of sandflies. So leishmaniasis is a parasitic infection that's transmitted by sandflies. And the result is there was a massive outbreak among people fleeing conflict associated with human migrations in Sudan and bordering on Ethiopia. And the estimates are that more than 100,000 people died. So this, from a form of leishmaniasis known as visceral leishmaniasis, also goes by the name of Kala-Azar. So this now, in my opinion, represents the most lethal conflict most lethal epidemic in all associated all modern warfare, and maybe the most lethal epidemic we've had in modern times, and yet it's gone almost unreported. I'll stop there and see if you have a question.
Yeah, I just want to ask you about, you mentioned refugees. Why would the influx of refugees create a better climate for sandfly bites? That's
a good question. So it's more of a consequence that when people are fleeing conflict zones and therefore sleeping outdoors, sleeping under conditions of exposure, they're susceptible to the bites of sandflies. And this is not unique to refugees. So, for instance, when our troops went into Iraq and later in Afghanistan, and they were for instance, when a lot of our U.S. troops were bivouacked in Kuwait and in Iraq during the invasion to get Saddam Hussein out, they were also massively exposed to sandfly bites, and they were exposed to this infection, although it was a different form of the infection, only associated with skin lesions. But I'll come back to that in a minute. But in terms of the visceralizing form, Kala-Azar, that killed so many people in Sudan, this is a disease that produces a leukemia-like illness where it destroys the liver, the spleen, and the bone marrow, and makes people unable to fight infection. So if somebody were to come with the Kala-Azar visceral leishmaniasis to the U.S., they usually get misdiagnosed as having a leukemia because many physicians are not aware of this disease. But it has devastating consequences. We've seen it again now in Syria. So Syria has always battled leishmaniasis, but a different form of the disease associated with disfiguring ulcers on the skin. And the locals call it Aleppo evil, referring to the one of the major cities in Syria. Now, with the civil conflict there, again, you have a breakdown in public health infrastructure. People fleeing conflict, people are exposed to sandfly bites. They also there's also a lot of absence of garbage collection, refuse collection, and so this also helps the sandflies proliferate. So you get the perfect storm of sandflies as a consequence. Now the estimates are more than 100,000 cases of Aleppo evil have struck the people of Syria, many of them kids. The reason it's a problem is it produces a disfiguring ulcer on the face that, unless you get treated by injections into the skin of an antimony-containing compound to treat it, you can be scarred for life. And this particularly hits girls and young women who are, as a consequence, rendered unmarriageable, or it's grounds for spousal abandonment. So it's a very stigmatizing lesion as well. And in some cases, the sandflies may be following refugees into camps along the border with Turkey, along the border with Lebanon as well. And the frustration, of course, is that the World Health Organization just cannot safely operate in Syria right now. So they're kind of at the margins of a lot of this devastation.
Yeah. And you mentioned there's several types of leishmaniasis. And another thing in your article that you clearly articulate is the need for a vaccine for this parasite. And it's interesting, in a time of the political back and forth, you make a very unusual suggestion. You call for, in your words, vaccine diplomacy. And you're talking about a joint U.S.-Iran cooperation to develop and test new vaccines. Can you talk a little bit about that?
Sure, happy to. So I've been advocating now for stockpiling of leishmaniasis vaccines for crisis situations such as these. And in fact, I was on a panel discussion this week. The Gates Foundation, together with the World Health Organization and the NIH, held a meeting at near the NIH campus in Bethesda, where talked about the need for stockpiling a vaccine in conflict situations. Now, in terms of developing and manufacturing a leishmaniasis vaccine, the problem is who's going to pay for it. So this is a neglected tropical disease. By definition, these are diseases that only affect the poorest of the poor, people living in extreme poverty. And the major pharmaceutical companies are not positioned to make such vaccines. So we're developing them in the nonprofit sector. So our organization, the Sabin Vaccine Institute Product Development Partnership, which is based at Texas Children's Hospital and Baylor College of Medicine in Houston, is developing a first-generation recombinant leishmaniasis vaccine. Now, ultimately, though, we're going to need a partner who's going to scale it up. And the question is, who does that? Well, we've increasingly, in our product development partnership, have been looking to about a dozen IDCs, innovative developing countries. These are countries with great pockets of poverty, but have learned to punch above their weight in terms of making products. So examples are the Brazilians, for instance, make most of their own vaccines. The Mexicans now make vaccines. But in the Middle East, there's limited abilities, but one of the countries that can make vaccines are the Iranians. Have had some interest and success at trying to develop some prototype leishmaniasis vaccines, including places like the Institute Pasteur in Tehran and others. So I've been advocating for why aren't we partnering to work on this together, share knowledge, best practices, and work together to make a vaccine. Now, it's not as crazy as you might think.
No, I don't think that.
Many people don't realize that the oral polio vaccine that we all took as children was developed as a Cold War collaboration between the United States and the Soviet Union. Right. So Dr. Albert Sabin developed that oral polio vaccine jointly with the Soviets right after the Sputnik launch. At one of the worst times in the Cold War, the vaccine was jointly tested on 10 million Soviet school children. Ultimately, every Soviet citizen under the age of 20. Did this in collaboration with Drs. Chumakov and Zhdanov and Smardentsov and others. And that were the studies that led to licensure of the oral polio vaccine. So as an example, how two countries could put aside their ideologies for purposes of making a life-saving product. This is not taking any business away from the pharmaceutical companies. They're not going to go into leishmaniasis vaccines anyway.
Right.
It seems to me that this is a reasonable place to begin. I mean, now there's a lot of political and so there's a lot of political hurdles to trying to prevent that, but we're now engaged in some interesting dialogues with partners to see if we can make this happen. The thing that's very important, I think, is not to try to do this by going through the back door. This has to be done in a very open and transparent manner with the full cooperation of both the U.S. and the Iranian governments, and that's not an easy one, but something we're working towards.
No, I think that's a fantastic idea, and vaccine diplomacy certainly would break down some of the barriers, I believe.
Right.
Yeah. And you wrote another article, a little bit older. You published it on the PLOS blog back in January, and it was titled Tropical Medicine Mystery, Something is Killing Young Men in Central America. What is going on there?
Well, it's a great question. It's something that we're just starting to get our arms around. So in 2002, it was noticed in the major hospital in San Salvador, the capital of El Salvador, that there were huge numbers of patients, most of them young or middle-aged males, without the traditional risk factors for getting kidney disease, such as hypertension or diabetes, coming down with severe and, in some cases, fatal renal failure. And it seems to be striking mostly young males who are working in the sugarcane plantations, sugarcane fields on the Pacific coast of Central America. So it's not only in El Salvador, it's in Guatemala, Nicaragua, and even in Costa Rica. And by some estimates now, there have been at least 20,000 cases and maybe deaths from this condition that's tentatively being given the name Mesoamerican nephropathy. So there's a lot of mystery as to what's causing this, and not really a lot of sound epidemiological investigations, doing case-controlled studies to really fully characterize this condition. And then there's a lot of controversy as to about what might be the etiology, the cause of it. There's been a number of theories thrown around, among them that it's severe dehydration combined with a high fructose diet, which rings hollow to me, because people have been getting dehydrated in the sugar cane fields of Central America for the last 500 years, beginning with the Middle Passage of the Atlantic slave trade. So to me, that doesn't make a lot of sense. There's been theories about heavy metal poisonings or some toxin in the environment. That's a possibility. We've been suggesting that there's some possible infectious etiologies that could be looked at, such as a hantavirus or leptospirosis, or one of our faculty at the National School of Tropical Medicine, Christy Murray, has found that West Nile virus is linked to chronic renal disease, and a high percentage of people who get infected with West Nile virus go on to develop renal disease and even renal failure. So we're interested in looking at that as well. So we're hoping to get involved in investigating this outbreak. It seems to be a good fit for our National School of Tropical Medicine to get involved with that.
Yeah, Dr. Hotez, I only got a couple minutes left, and since we don't know the etiology of this problem, I mean, what can be done at this point? Well,
I think what looks to me that's happening, and again, this is just from somebody on the outside looking in, it seems to me that efforts are not being all that well coordinated. We need to have active involvement of the Pan American Health Organization. I would think our Center for Disease Control and Prevention needs to be actively engaged, together with a community of academic scientists and reference laboratories to make this all happen. It's a good poster child for what a neglected tropical disease is. If this kind of thing were happening, if you had 20,000 people with chronic renal disease all of a sudden in, I don't know, where are you based?
Tampa.
Tampa, if you had this happening in Tampa or in Bethesda, Maryland, or you name it, we would never tolerate it as a society. But because it's occurring among the poorest of the poor in Central America, we're now allowing what some people describe as entire widow villages of widows, to appear on the Pacific coast of Central America. And so we need to do a better job. These are diseases that are occurring right in our own backyard. And to me, it's very sad how when you go to Central America, you can fly 3 hours from Florida or Texas, and you can go back in time 300 years. And,
sure.
And we can't allow that.
Well, I like to say these were very fascinating articles. I'll be posting links to the articles on the website.
Great.
And if you want to learn more about neglected tropical diseases, next Saturday I'll be talking to Dr. Neeraj Mistry from the Global Network about the End 7 campaign, which I know you're familiar with, sir.
Right, that's part of our Sabin Vaccine Institute.
Absolutely.
So I'm sure you'll enjoy speaking with Neeraj.
Right. And so I want to thank you, Dr. Hotez, for coming on the show and giving us this sad but real-life information. I appreciate it, sir.
Great, thanks. I hope I can come back sometime and give you a follow-up.
Oh, absolutely. Thank you, sir.
All the best.